Assalamu alaikum dear doctors. In this video I am discussing about the differential diagnosis and important for all history collection. How can we collect the history of different points? Now first one, the complaint is raised. If the complaint is raised, how can we exclude? First we ask the OCD when it started the rash. How long he is suffering the rash? Is there any aggravating factor, precipitating factor or inhibiting factor for the rash? Then, is the rash is associated with itching, blanching or not? Distribution of the rash, very important distribution of the rash. We know that Hanoscolin purpura, measles, different distributions. We can exclude the DD. Then describe the rash. Other family members affected with this rash or not? Fever, analyze as below. Okay. Then timing of the rash with fever. Did it start all together or the fever subsided then the rash appears? So lots of disease we can exclude for that. And now DD of fever with rash. When a person complains fever with rash, what are the DD comes on our mind? These are infective, bacterial and viral. Bacterial fever with rash are scarlet fever, meningococcemia, mycoplasma, eczema, herpeticum. Viral fever with rash are measles, rubella, mumps, chickenpox, varicella zoster, Epstein-Barr virus, that is infectious mononucleosis, HHV6, roseola infantum 6th disease, parvovirus B19 5th disease equal slapped cheek syndrome, Coxsackie A16, that is hand, foot and mouth disease. Now malignant causes of fever with rash. These are leukemia and lymphoma. Autoimmune or vasculitis causes of fever with rash are SLE, Hanoscolin purpura, Kawasaki, GIA, systemic onset. And drugs causes fever with rash, that is Stevens-Johnson syndrome and toxic epidermal necrolysis. The second was complaint is fever. So again fever, OCD, when it started, how long the fever he is suffering, is there any triggering factor or inhibiting factor of the fever? What are the questions we ask in fever complaints? How did you measure this fever? What is the highest degree? What did you do to lessen it? Was it controlled by medicines? Was it accompanied with rigors? Is it the same all day or it increases by night? Because malignancy, tuberculosis, arthritis, we need to exclude. Number 3 complaints is arthritis. So arthritis, we are OCD again. When it started this limping and how long he is suffering, is there any aggravating and relieving factor? Then for arthritis plus JSR2F. So let's see. J for other joints. Is that other joints involved or not? Then number S is signs of inflammations. That is, we exclude that it is red, hot, painful, swollen, limited movement. Via this, we know that inflammation present or not. R for rash. Is it arthritis with rash? F for fever and flu. So we know one of the important arthritis of rash is Hanoscolin purpura. DD of arthritis. When arthritis complains, what are the condition in our mind? That is acute and chronic. Acute is reactive arthritis and septic arthritis. Among them, septic arthritis, we all know that is sign of inflammation. It is high fever. Septic arthritis patient is toxic. And chronic arthritis, if then we think juvenile idiopathic arthritis, JIA, very important. It is come on the exam. Lupus, rheumatic fever and psoriatic. Number 4 complaints is failure to thrive, faltering growth, that is bitter synonym. Okay, so failure to thrive, the child is not growing well, the mother is complaining. Then we again take the history, OCD, when it started, when first you notice that, and how long he is suffering that growing, not growing properly. Is there any triggering factor or any inhibiting factor of this faltering growth? Plus ALE. What is ALE? Number A is appetite. How is his appetite? What type of diet he is taking? Who is carrying him? Who is giving him food? We'll ask. L for loses. That is vomiting, diarrhea presence or not. Is diarrhea 5FS? Frequency, fever, food content, foul smell, flush difficulty. We'll exclude because diarrhea, we know that flush difficulty, that is celiac disease. And E for evidence. How did you notice it? Clothes, weight loss or pears. So comparing pears, is there loose clothes? Then we can evidence of growing chart and plus growth chart. Now DD of faltering growth. When there is complaint faltering growth, what are the DD comes on our mind? Number 1, decrease intake. For decrease intake is that neglect, severe fussy eater. Okay. Next is increased loss. How? Parasite, repeated gastroenteritis. Increased needs, that is chronic illness as cystic fibrosis. Then malabsorptions, faltering growth are celiac disease, cystic fibrosis and GERD disease. Now number 5 is pain. When someone complains that pain, what are the questions we'll ask and take the history? First OCD, how long, when it started, how long suffering, any triggering or inhibiting factor. Plus star, STAR. S for site, severity 1 to 10. So the pain is where locations and severity, how much you give the grade 1 to 10. Number T is the type of the pain. That is maybe any type. Number A is association. The pain is associated with headache. If headache, then we'll ask plus blood vision, nausea, morning vomiting. Because morning vomiting for brain tumor, we know. Tummy pain plus vomiting, changing in the bowel. Arthralgia plus joint swelling and fracture, we'll ask. Plus radiation. Is the pain is R for radiation, pain is localized or radiated, other side or not, we'll exclude. Now DD of headache. Someone complaining headache, what are the DD? These are organic and non-organic. Organic is inside CNS, outside CNS, two divisions. So inside CNS organic cause are abscess, meningitis, encephalitis and tumor. Outside CNS of organic are sinusitis, rhinitis, ER and teeth. Now all non-organic causes of headache DD is that migraine, cluster headache, tension headache, analgesia related, pseudotumor cerebri. All have different characteristics, we know. Now DD of abdominal pain. Someone complaining abdominal pain. What are the DD comes on our mind? Organic and non-organic, both causes. So organic causes of abdominal pain are or tummy pain, medical, diabetic ketoacidosis and lymph nodes. Diabetic ketoacidosis, just when tummy pain someone complains, come on your mind, that is diabetic ketoacidosis can be. Surgical cause like appendicitis, intersusception. Option gynecos, imperforate hymen. Now, non-organic causes of abdominal pain. These are functional abdominal pain, functional dyspepsia, inflammatory bowel disease, and abdominal migraine. Number 6 complaint, someone complaining bleeding. What are the history? Will take bleeding. First OCD, that onset when it started this bleeding, how long he is suffering this bleeding problem, and there is any aggravating or inhibiting factor. Plus HOCAB. H for hemodynamically stable. Plus fainting or awareness of the heartbeat. So the patient bleeding, then first we will exclude that hemodynamically the patient is stable or not. Then onset, O for onset, and the color. The color patient pee poo, all these we exclude. Pee or poo color, there is blood present or not. Then amount of the bleeding, A for amount, B for bleeding from other sides. Then epistaxis, if epistaxis, then one side, both sides, how was it stopped? Hematemesis, any food particles. Then pallor history, again OCD and plus HOCAB. Similar bleeding history we'll ask. Now, number 8 is short or obese. Short or obese patients, how can we exclude? That is OCD plus FOPSM. OCD onset, course and duration, when it started, how long suffering, is there any aggravating or triggering factor and inhibiting factor. Then FOPSM. F for features. Short, how is his features, dysmorphic features, maybe we shouldn't exclude. Then onset, when first the mother noticed that he is not growing, he's short or obesity started, we'll ask. Then puberty, if the patient age is corresponding to puberty, we'll ask that puberty. Patient parent, we'll exclude the parent puberty is delayed or not. There are sometimes that parent has the history of delayed puberty and the child is also getting this. Yes, school performance, how is his school performance? Because we know hypothyroidism also associated with short and obese, and the school performance also deteriorated. Then M for measurement. We measure if short patient weight, height, BMI, mid-parental height and sitting height. Now, short and non-obese. The patient is short but he is not obese. What are the cause? Proportionate cause and disproportionate. Proportionate short, non-obese are normal IQ, that is familial, constitutional, chronic illness, Russell-Silver and XPT. So that is normal IQ present. Now, decreased IQ and short stature, that is Turner, Noonan, Williams syndrome, Cornelia, Dillon syndrome, and these are. So, decreased IQ, we are seeing that all chromosomal disorder, easy to memorize. Now, disproportionate. Normal IQ, we find achondroplasia, hypochondroplasia, rickets, osteogenesis imperfecta, Ellis van Creveld. And decreased IQ, we find mucopolysaccharidosis and Sanfilippo. DD of obesity. When a patient complains that obesity, chief complaints, then what are the DD comes on our mind? If short and obese, normal IQ and decreased IQ. So normal IQ, short and obese persons are endocrine cause like growth hormone deficiency, Cushing syndrome, hypoparathyroidism and pseudohypoparathyroidism. Decreased IQ occur in syndromes, that is easy remember, Down syndrome, Prader-Willi syndrome, Lawrence-Moon-Bidal syndrome and Bardet-Bidal syndrome. And tall stature we find simply can be by simple obesity. The person is tall and some obese. Then Beckwith-Whiteman syndrome and Klinefelter syndrome. That is very easy exclude. Beckwith-Whiteman syndrome, we will ask about the ear, size of the ear, tongue. And Klinefelter syndrome, that is patient mentality. He is mentally disordered or not. So Klinefelter syndrome. Now number 9, fainting attack or abnormal movement. Someone complains fainting attack, abnormal movement. First we exclude the red flag. What are the red flags of fainting attack, chest pain related to exercise, family history of sudden death plus sudden infant death. Analysis of complaints. What happened? So before this fainting attack or abnormal movement, what happened? We'll ask. Before, during, after. Video recording, fever, first time, recurrent or frequency. Then past to history, we'll ask that any trauma, past any trauma and CNS bug. That meningitis will exclude. Now DD of fainting attack, someone complain fainting attack, what are the DD come on our mind? Organic and non-organic. Organic DD of fainting attack are CVS, arrhythmia, long QT, Wolff Parkinson White syndrome. Structural cause are acute stenosis or hypertrophy obstructive cardiomyopathy. CNS drugs is tricyclic antidepressant and antihistamines. Metabolic causes of fainting attack are hypoglycemia, inborn error of metabolism. So for hypoglycemia, we take the feeding history and blood sugar measured or not, we will ask. Non-organic are vasovagal and malignancy. Now DD of fit, someone fit, complain, what are the DD come on our mind? Organic and non-organic. Organic cause are CNS, any trauma, infection, tumor, epilepsy, hemorrhage, drugs, illicit drugs, that is ecstasy. Metabolic cause are hypocalcemia, hyponatremia, inborn errors of metabolism. Non-organic causes of fits is that is breath holding spells. So this is all about the differential diagnosis of our history. Please do subscribe and share. MRCPCH with Dr. Emma Choudhury. Thank you.